Hi everybody, I am Dr. Raina Chawla, your faculty for Obs and Gynae, and in this session we will be discussing a very high yield topic called teratogens. Okay, so questions usually come from this topic. The examiners love to ask rarer things. Okay, and this is one of those things which you cannot afford to miss, and you should know. It's a very small topic. Let's discuss this. So the topics we will discuss under this are: number one, what is a teratogen and how does it actually affect the fetus? And number two is the important teratogens. So we'll cover the ones which have come in questions, the potential ones that can come as questions. Okay, so first of all, what is a teratogen? So a teratogen is basically a drug. It is a drug or a metabolite, or it could be an environmental factor, say radiation, which causes fetal abnormality. Okay, and in this session we will be mainly discussing the drugs that can cause fetal abnormalities, the other factors, for example, how diabetes causes fetal malformations or how radiation causes fetal problems, we will discuss in that topic. Okay, so it's very important to remember that teratogenic exposure must occur during a critical developmental period, that is the period of organogenesis. Okay, so different organ systems develop in different periods of gestation, and depending on when the teratogenic exposure occurs, that organ system may be affected. It's also very important to remember three other things. Okay, number one, the all or none phenomena. Now, what does the all or none phenomena mean? It basically means if the teratogenic exposure is during the pre-implantation period. What is the pre-implantation period? It is the period from fertilization to implantation. And if the teratogenic exposure occurs at this time, then either the fetus survives the insult or the fetus dies. It does not get implanted at all. So it's either all or none. It completely survives or it completely doesn't grow at all, doesn't even implant. So this is called the all or none period. Okay. The second thing is to remember is what is once the fetus is implanted, it is called the embryonic period till the 8th week post conception, and this is called the period of organogenesis. So, 2nd to 8th week post conception is called the period of organogenesis, and this is where most organ systems form, and insult and at this time causes major problems. The fetal period is beyond the 8th week post conception, and in this period, some organs remain vulnerable. So, if you look at this chart here, here is where the all or none is happening. This is pre organogenesis from fertilization to implantation. So, if the insult is occurring here, so if the insult happens here, either the fetus will completely survive and nothing will happen to it, or the fetus will completely die. Okay, so this is the all or none period. Now, the important period which you should know for organogenesis or for teratogenicity to happen, affect most, is in the embryonic period, that is till the 8th week of gestation. So this, the black here, the black lines, this is the CNS, this is the heart, this is the ear, the eyes, the limbs, the face. Okay, the black line means the fetus is most vulnerable for these systems at this time, and you can see most of the vulnerability is before the 8th week, or actually before in the first trimester, okay, till the 10th week maximal. Okay, so the insult happening in the first trimester is very important. This is the period of organogenesis, especially the embryonic period, that is till the 8th week of gestation, is where majority problems will happen if teratogenic exposure has occurred. So let's come to each teratogen one by one and see what are the important things we need to remember for each teratogen. Now, starting with alcohol. So alcohol, remember, causes fetal alcohol syndrome, And also remember, it is the leading cause of preventable developmental disabilities worldwide. It is preventable, okay, and it is the leading cause of preventable developmental disabilities worldwide. Fetal alcoholic syndrome is characterized by two things. Number one, neurobehavioral delay, or it affects the behavior of the child, and number two, it causes facial anomalies. Okay, what kind of facial anomalies? There'll be microcephaly, micrognathia, there'll be epicanthal folds, small palpebral fissures, a small nose, okay, and a flat philtrum. So these are some of the features you would see with a baby with fetal alcoholic syndrome. And remember, it is the leading cause of preventable developmental disabilities worldwide. The next important teratogen which we should know about are anti-epileptic drugs. Now, anti-epileptic drugs are very important teratogens. In fact, preconceptionally, we ask the woman specifically this history and try to change over to a safer drug. Also, we try to change from multi-agent to single-agent therapy. Now, what do anti-epileptic drugs cause? Remember, they cause orofacial clefting like cleft lip and palate. They also cause neural tube defects, and they also cause cardiac defects. Okay, multiple agents. The more the number of anti-epileptic drugs she's taking, higher is the risk of anomalies. Remember these two drugs. The newer drugs, levetiracetam and lamotrigine, are safe in are not completely safe, but they are the safest anti-epileptic drugs. So if you want to shift her over to levetiracetam and lamotrigine. Now remember the drugs which are not good. Okay, so this picture shows fetal hydantoin syndrome, which is classically seen with phenytoin. And what does fetal hydantoin syndrome consist of? It basically consists of midfacial hypoplasia, an upturned nose, and distal digital hypoplasia, that is short fingers and short toes. Okay, so these are characteristically seen with fetal hydantoin syndrome. Also remember, the maximum risk of anomalies is with sodium valproate, followed by topiramate, followed by phenytoin and carbamazepine, followed by phenobarbital. Okay, so sodium valproate has the highest risk of teratogenicity, followed by topiramate, phenytoin, carbamazepine, and phenobarbital. The safest drugs are lamotrigine and levetiracetam. So these are the safe drugs. Fetal hydantoin syndrome, you should know what it consists of. It consists of midfacial hypoplasia, an upturned nose, and distal digital hypoplasia. Now, the next important drug you should remember, which is teratogenic, are ACE inhibitors and angiotensin receptor blockers. Okay, these are basically anti-hypertensives. Okay, and if a woman is taking these preconceptionally, again you need to shift her to a safer anti-hypertensive, which could be labetalol or it could be calcium channel blockers. These are the safest in pregnancy, or alpha methyl dopa. Now, AC inhibitor fetopathy is what is the problem caused by AC inhibitors or ARBs, that is angiotensin receptor blockers. What do they cause? They cause renal hypoplasia or even renal agenesis in the fetus. So if there's renal hypoplasia or agenesis, what happens is that the kidneys of the baby don't develop and there is early onset oligohydramnios, or if you find oligohydramnios in the second trimester, always think of a fetal renal problem. Okay, and because it occurs so early on, what will happen to the fetus? The fetus will get compressed. okay, and look like this. What is this called? This is called Potter's sequence. What is Potter's sequence? It occurs because of oligohydramnios, early oligohydramnios. So oligohydramnios in the second trimester, which could happen because of renal agenesis or hypoplasia of the fetal kidneys, which can happen because of ARBs or AC inhibitors. Okay, what this will cause? It will cause pulmonary hypoplasia. So the lungs don't develop because there's no place inside for the lungs to expand, and because of the oligohydramnios, there is fetal compression. So imagine the baby inside the uterus with no protective cushioning of the liquor around it. So it's compressed directly by the uterus. So the limbs don't develop. There are limb defects. Okay, there's facial defects like low set ears, there'll be a beaked nose, there'll be prominent epicanthal folds, and of course there's pulmonary hypoplasia. So what is Potter sequence? You have Potter facies, that is a compressed looking face, you have pulmonary hypoplasia, and you have limb deformities because the baby has no space at all for any sort of movement, and that too very early on in the second trimester. So this is called Potter sequence. It's been asked before, very important. Where do you see it? Usually if there's a fetal renal agenesis or hypoplasia where the kidneys don't develop, so the fetus does not produce urine. If there's no urine, there is no liquor, and this ends up in this fetal compression syndrome called as Potter's sequence. It is important here because which teratogenic drug can cause Potter sequence? AC inhibitors and angiotensin receptor blockers cause AC inhibitor fetopathy, which can lead to this problem. Next important teratogen we should discuss is indomethacin, okay, or NSAIDs. In this, important is indomethacin. Where do we use indomethacin? Can you recollect and let me know? Where do we use indomethacin in obstetrics? We use it in polyhydramnios. Very good. We use it in polyhydramnios. We also use it as a tocolytic. Okay, so it has two main uses in obstetrics. But if you go back to your chapter on polyhydramnios and tocolytics, remember indomethacin is never given after 32 weeks. It is indicated only in women who are in period of gestation less than 32 weeks. Okay, because after 32 weeks, what does it cause? If it is given for prolonged period of more than 72 hours, it causes premature closure of the ductus arteriosus, and this in turn causes fetal pulmonary hypertension, okay, which could be lethal also to the baby. So remember, indomethacin is an NSAID. It's very important because it has two uses in obstetrics. Polyhydramnios, it reduces the amniotic fluid, and tocolytic, it causes relaxation of the uterus in a patient who comes with preterm labor. But we never give it after 32 weeks, especially for more than 72 hours, because if we do, it will close the ductus arteriosus prematurely, and that can cause pulmonary hypertension in the fetus and the baby can die. Less than 32 weeks, it doesn't cause this. The sensitivity of the ductus arteriosus to indomethacin has been observed only after 32 weeks. This has come as a question as recent as NEETPG 2021. So you have to understand these drugs, very, very important. Okay, next is aminoglycosides. So aminoglycosides, so we'll talk about antimicrobials in general. In this, the important ones we'll let you know what are important to know. Aminoglycosides are contraindicated in pregnancy because they are ototoxic and they are nephrotoxic to the fetus. Okay. Nitrofurantoin is contraindicated in the first trimester. It is contraindicated in the first trimester because it leads to clefting. Again, cleft lip and cleft palate can happen. It is also known to cause hypoplastic left heart syndrome. Okay, but this is only if the exposure is in the first trimester. Then we have tetracyclines. Tetracyclines cause yellowish discoloration of teeth, and that's why it should not be given. It is best avoided. Sulfonamides are known to cause neonatal hyperbilirubinemia. These are the antimicrobials which you should know when asked a question: which antimicrobials are safe, which are not. Usually all cephalosporins can be safely given. The ones you should avoid or give with caution are aminoglycosides. Nitrofurantoin, especially in the first trimester, should not be given. Tetracyclines should not be given, and sulfonamides should not be given. Anti-neoplastic drugs are category X. What does category X means? That they are lethal. They should not be given to the fetus. They are absolutely contraindicated. Okay. Now let's discuss the important ones which are associated with known anomalies. One is methotrexate. What does methotrexate cause? Methotrexate causes craniosynostosis, also called a clover leaf skull. Okay. Tamoxifen, which is given commonly in breast cancer survivors. Okay. Tamoxifen is known to cause multiple lethal anomalies, and especially it is known to cause vaginal adenosis in female fetuses. Also, very important to know about tamoxifen is if a woman who has had breast cancer has been on tamoxifen post treatment, okay, she wants to conceive. So, for how long after stopping tamoxifen should she be allowed to conceive? And this has been asked in the recent INICET, and the answer is 3 months. Okay, after stopping tamoxifen, because that is the time that it takes to wash out from the body. 3 months gap should be given before asking her to attempt conception. Trastuzumab is also a known teratogen, and this is known also given in breast cancer. This is also known to cause skeletal abnormalities and also pulmonary hyperplasia. Okay, pulmonary hyperplasia. Now coming to lithium, I think all of you know this. Lithium is a minor teratogen. That means the risk of teratogenicity is less, but if at all it is very strongly associated with causing Epstein's anomaly. So remember, lithium causes Epstein's anomaly. Retinoids are again contraindicated in pregnancy. They cause isotretinoin embryopathy. And what does this embryopathy cause? This embryopathy basically causes microtia or anotia, that is small or absent ears, is the characteristic finding in isotretinoin embryopathy, apart from other anomalies characteristically associated with small or absent ears. Okay. Now, thalidomide, a very commonly asked question. Okay, so thalidomide, few interesting facts about this drug. What was it used for? So, in the 1960s, especially in America, it gained popularity for being an anti. Can anyone remember or know what it was? It was used very commonly as an antiemetic in the first trimester of pregnancy. Okay, it was thought to be safe then. Okay, at that time, not many studies would be done before advising drugs, especially in pregnancy. So it was given very commonly for nausea and vomiting of pregnancy, for hyperemesis in the first trimester. Then what happened? So many fetuses were born with multiple anomalies, so many stillbirths were documented, so many anomalous fetuses were detected. Okay, in around about that time when thalidomide was started, and especially associated with phocomelia. Phocomelia means undeveloped limbs, okay, or shortened limbs, and this is characteristically associated with thalidomide, after which thalidomide was banned, okay, for use in pregnancy. But very important, what is it? It is an antiemetic. Okay, it has been asked as a question, as an image, it has come as match the following, it has come multiple times in the exam. Methimazole, okay, is given in hyperthyroidism. What does it cause? It is characteristically associated with a dermatological condition called as cutis aplasia. So remember, methimazole is known to cause cutis aplasia. Okay, warfarin, again very commonly asked question. Okay, warfarin basically causes warfarin embryopathy. It is also called as Dysala syndrome. Okay, and what are the characteristic findings? Two things. You have stippling of the epiphysis. So you have stippled epiphysis, so skeletal abnormalities, and nasal hypoplasia. A few important things you need to know about warfarin is that warfarin embryopathy occurs in doses if she's been taking more than 5 milligram per day, and if the exposure has been between the 6th to the 9th week of pregnancy, then the risk is highest. If we have a woman who has been taking warfarin, okay, say she has a mechanical heart valve and she's been taking warfarin, what needs to be done is as soon as she conceives, as soon as she becomes pregnant, she needs to be shifted to low molecular weight or unfractionated heparin. Okay, the therapeutic dose needs to be given, and that has to be continued throughout pregnancy, or preferably at least till the first trimester is done. Then you can re-switch to warfarin in the second trimester, and then re-switch to heparin again in the third trimester. Remember, apart from warfarin embryopathy, there is also a risk of intracranial hemorrhage in the fetus and in the neonate. Okay, so this is the problem with warfarin. As soon as she becomes pregnant, she needs to be switched over to heparin. Warfarin embryopathy occurs in doses of more than 5 milligram per day when the exposure is between 6th to 9th week of pregnancy. Now this is something new, okay, and I've put it here because this was a question in INICET November 2022. Okay, it's never been asked before, but now it has been asked. SSRIs are used in depression, okay, and how do they affect the fetus or the neonate? Do they don't affect? What happens? So remember, paroxetine is the only SSRI to have been associated with a fetal anomaly, and it has been found in some studies to cause fetal cardiac malformations. All other SSRIs are safe. So if a woman is on paroxetine who is contemplating pregnancy, preconceptually, please switch over to a safer SSRI, because paroxetine causes fetal cardiac malformations, commonly VST. All other SSRIs do not have teratogenic effect, but they do affect the neonate. How? Neonates who are born to mothers who were on SSRIs have been found to have something called neonatal behavioral syndrome. These are mild abnormalities which usually settle within 48 hours, but it has been found such babies are irritable, they have hyper and or hypotonia, they have feeding difficulties, and they have respiratory depression. But all these are mild and are self-limiting. Within 48 hours the baby improves. Okay, also very important, these babies have been found to have, okay, a small percentage of babies whose mothers were on SSRIs have been found to have persistent pulmonary hypertension. So this is very important. This has been asked in the INICET, so it becomes an important question now. So remember SSRIs and its effect on the fetus and the neonate. Now just a brief words on recreational drugs. Amphetamines are major teratogens. They cause multiple fetal defects. Opioid narcotics cause neonatal abstinence syndrome. Marijuana also causes significant fetal growth restriction and preterm labor. And smoking or tobacco, okay, what does this cause? This increases the risk of abortions, it increases the risk of preterm labor, it increases the risk of fetal growth restriction, and it increases the risk of antepartum hemorrhage. So remember these four. This is a very important question. Smoking can increase the risk of abortions, increase the risk of preterm labor, increase the risk of fetal growth restrictions, and increase the risk of antepartum hemorrhage. Now, this is a recap of most of what we've talked about. Okay, so it's a very, very important table. Okay, you can just take a printout, hang it up. Okay, it's in your notes, go through it. Very, very important. Keep going through this, quiz your friends, because this is something which will come again and again and again. Anti-epileptic drugs causes fetal Hydantoin syndrome. What is that? Facial features plus distal digital hypoplasia. AC inhibitors and ARBs, what do they call? They cause fetal renal hypoperfusion, renal agenesis, and this leads to Potter's sequence because of early onset oligohydramnios. Alcohol causes fetal alcohol syndrome associated with neurobehavioral delay and facial defects. Lithium causes Epstein's anomaly. Indomethacin causes premature closure of the ductus arteriosus, especially given after 32 weeks for more than 3 days. Methimazole causes cutis aplasia. Warfarin causes warfarin embryopathy. Thalidomide causes shortened limbs or phocomelia. Methotrexate causes clover leaf skull or craniosynostosis. And one extra one I have added here is diethylstilbestrol. This has come as a question twice now. Okay, this causes in female fetuses, it causes clear cell adenocarcinoma of the vagina. It also causes Mullerian anomalies like a T-shaped uterus, and in male fetuses it causes hypospadias. Okay, so what does it cause? It causes clear cell adenocarcinoma in female fetuses. It causes T-shaped uterus in female fetuses, and in male fetuses it has been found to cause hypospadias. So this is about the different teratogens and the anomalies they cause. Okay, so this table is very, very important. Please keep revising this table. You are definitely going to get a question from here. Okay, now a few MCQs. Which or this defect is associated with which drug? Which drug causes this defect? You can see there are short limbs here. So this is phocomelia, typical picture of which drug? Of thalidomide. Okay, which caused the thalidomide tragedy of the 1960s. Thalidomide was given as an antiemetic in the first trimester of pregnancy, and then fetuses born with limb defects were noticed, and then it was realized that thalidomide causes phocomelia. Clover leaf skull is seen with which teratogenic drug? And we know clover leaf skull is basically craniosynostosis, and this is seen typically with methotrexate. Okay, so you will get many such questions. You'll find many such questions in your previous year papers. Go through them, go through our MCQs, go through the table, and this is a very, very high yield area. You can't afford to go wrong with this. Okay. Another question, the ultrasonographic finding is consistent with teratogenic effects of what? Okay, so you can see here, this is a sagittal view or a cut section of the head and the face. And if you look carefully, you find that the nose, there is nasal hypoplasia. The nose is not clearly seen. Okay, and nasal hypoplasia is basically a feature of which drug, which teratogen? It is of warfarin. Warfarin causes nasal hypoplasia and stippled epiphyses. Okay, what does valproate cause? Valproate causes neural tube defects, facial clefting, cardiac defects. Thalidomide causes phocomelia. Phenytoin also causes the fetal Hydantoin syndrome. Okay, but what we're seeing here is a feature of warfarin embryopathy, that is nasal hypoplasia and stippled epiphyses. Next question, match the teratogen with the defect. Okay, so we have methotrexate. What does methotrexate cause? It causes a clover leaf skull. What does thalidomide cause? It causes phocomelia. What does misoprostol cause? Now we've not discussed this, but misoprostol, which is used in first trimester, mid-trimester abortions. Okay, so say a woman has taken misoprostol, but the MTP, the procedure was failed, she did not abort, and then she continues with that pregnancy. Her baby is at risk of developing Mobius sequence. Okay, what is Mobius sequence? It is basically cranial nerve palsy. Okay, so misoprostol, which is also called as prostaglandin E1, is known to be associated with Mobius sequence. What is Mobius sequence? Mobius sequence is cranial nerve palsy. What does valproic acid cause? Valproic acid is an anti-epileptic. It is known to be associated with facial clefting, cleft lip, and cleft palate. So this is the correct. Match the following. All or none effect is seen if teratogenic exposure occurs during which phase? Okay, so the all or none effect, remember, when does it happen? It happens before implantation. Okay, so it happens after conception but before implantation, and that is called the pre-implantation period. What is the embryonic period? Embryonic period is from the 2nd to the 8th week. After the 8th week is the fetal period. Preconception means she's not even conceived, okay, but pre-implantation is when the all or none phenomena happens. What is this all or none phenomena? Is that if the insult occurs during this time, either the fetus will die or the fetus will survive without any problems at all. Okay, so this is called the all or none effect or the all or none phenomena. Okay, so remember, success comes to those who act. Those of you who are willing to put in that effort will definitely see success. Thank you very much.